Hello, I'm Uchechi Okeke and I'm here to talk about convergence excess esotropia. I promised you in my former video, what is convergence excess esotropia? This is a kind of esotropia that occurs at near but at far the eye is straight or phobic. This kind of esotropia usually occurs in children within the ages of 2 to 5 years old. We know that this is when a metropization takes place and the accommodative state of the eye is at its highest within this age. Patients in this category would usually have their eye deviates when they're trying to maybe reach out to tiny details or, reach out to things that are near and they are very tiny, so they induce accommodation. But the main, associating factor with this convergence excess esotropia is the high ACA ratio. When a patient exerts one iota of accommodation, he or she simultaneously exerts more or excessive accommodative convergence, and so the eye deviates, and this is what is associated with convergence excess esotropia. This is also a differentiating factor from near esotropia. Convergence excess esotropia is an intermittent form of esotropia, and because of this, it's usually not associated with amblyopia. So patients really do not have amblyopia. However, patients have binocular single vision and they also have good stereopsis. This explains it. The patient is intermittent, so obviously the patient's eyes don't, it's not tropic all the time, and so it doesn't get dormant at any point, and that's why the patient still using his fovea and the patient can maintain binocular single vision. How is this condition treated or managed? First of all, this patient should be given full cycloplegic refractive correction, especially when this patient is hyperopic. If this patient is myopic, we might want to reduce the refractive correction. Another thing is, in giving the full cyclorefraction, we should also note that this patient will need an AD. This is because this patient has a manifest deviation at near or when the patient is exerting accommodation, and we want to take care of the accommodation. So we need to give this patient an AD, but we don't just give just any AD. We have to make sure that we give the patient the lowest AD that still maintains binocular single vision. We don't want to take away binocular single vision at near, or we want the patient to have binocular single vision at near rather. So we would want to give this patient the lowest AD that still maintains binocular single vision. Also, when giving this AD, we should make sure that we will make the near segment high enough to accommodate this patient's eyes or accommodate this patient's pupil when the patient is doing near work. We don't want to give an AD that will make this patient to still be looking at the distance portion when the patient is doing near work. So that's something to consider. And in doing this, we have to make sure that the frame is well fitted on this patient's face, so it doesn't keep, falling off or, not staying the way we want it to stay. These patients can also benefit from orthoptic exercises, and we might consider increasing the negative frictional reserve, because we are talking about, we want this patient to be straight and this patient is isotropic. So we might consider improving the negative frictional reserve. Also, this patient is not usually amblyopic, so there might not be need to, treat amblyopia. But if this patient has amblyopia, probably because of an isometropia or any other form of amblyopia, of course, we need to make sure that this amblyopia is taken care of, because that might also improve this patient's condition. So any form of amblyopia should also be taken care of. Surgery is a definitely important factor to consider for patients like this, especially most patients might not want to always be wearing bifocals all the time. And if this deviation is up to 20 to 25 prism diopters or more, we should definitely consider surgery for this patient. The option for surgery might be bimedial recession, or we might want to do a unilateral recess. So we either do a bimedial recession, that's by weakening the medial rectus of both eyes, or we might want to do a unilateral recess, or whatever option the ophthalmologist chooses to do, that's fine. Okay. Patients in this category would usually be properly advised. So the parents would be properly advised, on the need to wear the glasses. Probably if the patient is waiting for surgery, or the need to follow through with the exercises, and emphasized on the need to make this correction, as soon as possible, because of the year. This child is still young and is easier, treatments, the prognosis is actually, better, or, good if it's the earlier the treatment, the better. So these are things that we need to emphasize to the parents so that we have a very good outcome. Well, I hope I've explained the best I can. I will see you in my subsequent videos. Until then, please continue to take good care of your eyes. Enjoy yourself. Bye.